So good morning, everybody. Thank you for joining us in this community talk. I'm Foppe, I'm your moderator today, and we're here to watch this presentation from Lloyd about the physical activity IG. Are you ready?
I'm ready.
The floor is yours.
All right. That's me. I'm boring. Let's focus on the implementation guide. The slides are available if you want to learn more about me. Go to chat.fhir.org or whatever. First of all, this implementation guide is sponsored by a group called the Physical Activity Alliance, which includes American Heart Association and a whole whack of different organizations, some small, some pretty large, throughout the US that have an interest in getting people to exercise and use physical activity as a way to further their health. I've only got 20 minutes, so I'm going to go focus just on the IG itself. And there's only a couple of slides. The implementation guide can sort of be summarized in this diagram, which is from the homepage of the IG. On the inside is the 3 sets of systems that it's trying to get to share information. So we've got what we're calling Care Manager, which is typically electronic health records, EMRs, that sort of thing, but could be a social service agency, really anyone who is capable of looking at a patient and saying, you know what, you need to get more physical activity, that is capable of assessing and saying, is this patient getting enough exercise? And if not, making a decision to say, I'm going to help you, provide support for you to become more active, because we know that physical activity is one of the most effective things and one of the cheapest things that we can do to improve patients' health. And then we're looping in 2 other types of systems. We have a patient-facing system, which is any kind of system that is intended to be used by patients or their caregivers. So it could be mom, it could be a child, it could be anyone else who helps the person to interface with technology and talk about where they're at, respond to surveys, capture information about what level of physical activity they are or are not engaging in. And then we have service providers. And service providers could be clinicians, like exercise physiologists or physiotherapists, but it could also be personal trainers or a professional gym or something like that, YWCA, YMCA, anything like that. And the intention is to enable communication between these 3 different types of systems to better support patients in being more active. And we don't necessarily need all 3 of them to be involved. We have scenarios where it's just the care manager and patient engaging with each other. We have scenarios where it's just the care manager and service provider and the patient isn't actually involved electronically. And we have situations where it's just the patient working with the service provider and there is no clinician or care manager. All of those can work. We're just enabling the flows based on who is available to exchange and who is willing to exchange. In terms of what the IG covers, we start at the top with the assessment process, which is this person getting a sufficient level of physical activity in their life that's going to make a difference in their healthcare outcomes? And we have basically standardized the set of questions, and there's only 4, and one of the answers is calculated, so there's only 3 that a patient really needs to engage with. How many times a week on average in the last 30 days have you been getting moderate to vigorous physical activity? And then on those days that you did moderate to vigorous physical activity, how many minutes on average should you do? Those are the 2 that are sort of focused on aerobic. And then the last one is how many times per week did you engage in strength-based exercise? And if we get answers to those 3 questions, we can evaluate the patient against, in the US, they have national guidelines based on age for how much physical activity should you be engaged in. And if you are or are not hitting those, then that gives us an indication that maybe we have a problem. And the other thing that can happen at that point, assessment point, is creating a condition that says this person has a low level of exercise, low level of physical activity, and that's a problem we can stick in their problem list and then start to worry about interventions. If you're doing great and you're not like most people in North America, then that's probably where things start or stop. Except maybe a year later when we ask the same set of questions and say, how are you doing now? Although you could have a plan to say, great, you're doing awesome. How can I support you and make sure that that continues and reinforce that what you're doing is a good and necessary thing and is actually the best thing that you can be doing for the other health problems that you've got. But if, like most people, you're not necessarily as active as you should be, then we move on to the next phase, which is plans and goals, where we can talk about, okay, you're not where you ought to be. What is a reasonable target for you to get better, and what are reasonable dates for you to get better? And those goals might be around step counts, they might be around number of times that you're exercising, they might be around calories, whatever is meaningful to that individual and what is practical for them to measure. If they've got devices, then there are certain things that are easy for them to measure. If they don't have devices, then maybe we're just talking about number of minutes or number of times per week that they're doing something. And plans, what are they going to do to be more successful? How are we going to adjust behavior to better meet what they're mutually agreeing is a desirable end state? Prescription referral, we use both of these terms. We're using the word prescription to refer to an order to the patient. So I am prescribing you exercise. I am saying you need to be getting in 2,000 steps a day on average, or you need to be going to the gym 3 times a week, or whatever the order is. Because we have research that shows if you actually put on a prescription pad and give it to the patient, you need to do this, they respond more than when you just talk to them. And so we have the notion of being able to pass to the patient application, here is your prescription. And sometimes that's all you need to do. Referral is when you're bringing in somebody else. You're bringing in one of those service providers, whether it's a physiotherapist who can help figure out what are the motions that are going to work for you now that you've been injured, or whether it's a gym who will put together a training regime that's actually motivating to you and that works for you, but bringing in some external party to assist in that process. And there's a bunch of workflow around that in terms of how do you ask for somebody to help, and how do they say yes or no, and how do you report back the results, etc. Monitoring is how do you keep track of what's happening? Maybe it's just asking those 3 questions on a semi-regular basis and tracking how that changes over time. But we also have the ability to capture more information, like I went for a run. That run was 25 minutes. Here's how I felt. This is the number of minutes in that run that I felt were vigorous, or this is my average heart rate, or this is the number of calories that according to my iWatch that I happen to burn. Or we can capture this is the number of steps that I did throughout the day. So this ability to share not your fine-grained measurements of my heart rate was this, then my heart rate was this, then my heart rate was this, because most of the systems involved don't want to have that much information available. But on a day-by-day basis or an activity-by-activity basis, having a sense of what you're doing is of interest to some care managers and is of interest to most service providers, so being able to capture that. This implementation guide is actually built on top of the Gravity Social Determinants of Health implementation guide. We found there's a lot of overlap between social determinants like are you getting appropriate access to food, or are you getting appropriate access to transportation, and the physical activity space. First of all, there's a significant overlap in terms of patient target audience. If you have social determinants issues, you probably also have issues with access to good physical activity opportunities. But also, we are engaging in a non-traditional community of service providers. So social determinants of health, you're talking about food banks, you're talking about social services agencies who are often not terribly well integrated in the healthcare system. In our implementation guide, we're talking about engaging with gyms. We're talking about engaging with personal trainers who, again, don't often have super robust IT capabilities. And on the other hand, we have national chains of fitness centers that have pretty robust physical activity or IT capabilities. And so we need to handle that range. One of the things that Gravity defines is a patient engagement mechanism where you can assign tasks to a patient and say, hey, could you please watch this video? Or could you please read this article? Or could you please respond to this quick survey? And that's a useful thing to do in the physical activity space as well, to be able to say, hey, how is this regime going for you? Or I noticed that you're sort of falling behind on this part of your training, and so I'd like you to take a look at this video, which might help you better understand what it is that you need to do. Then we've got a reporting piece, which is if you've made a referral, how does the referred to agency or individual report back how things went? So, yeah, the patient came to 8 out of the 10 sessions. They seem to be engaged. Here's what I think we should do next with them. Most of these things are not mandatory. So you don't necessarily always have reporting. You don't necessarily always have monitoring. They are sort of pieces that you can choose to implement or not based on what your capabilities are and what makes sense for that particular patient. In terms of how all of this maps into FHIR, on the assessment side, we've got observations, and we've actually been successful at getting those observations into US CDI, or unless something changes at the last minute, which means that there will be an expectation at some point for EHRs to be able to capture this type of information. We also have a standard ICD-10 code that we can use for diagnosis in a condition if that's deemed to be relevant. We have care plans to capture the planning and goals to capture where we would like to be using Lloyd for those. The heavier borders are the things that we expect systems to be capable of. You have to be able to do the base assessment piece. You have to be able to do the referral piece. Whether you do conditions or plans or goals or ongoing monitoring is sort of up to you as a system, whether that's valuable to you. We've got observations for the ongoing monitoring. We've got tasks for patient, and we've got diagnostic report for the PDFs. The actual implementation guide is here, build.fhir.org, HL7 physical activity. And I would invite you to take a look at it. It's the implementation guide that I've enjoyed the most. I've created probably 40 implementation guides over my career in HL7, and I'm the most pumped about this one. It's a really cool project, and it's really sort of brain dead obvious use case of cheap, easy intervention and makes a huge difference for a wide number of people. The implementation guide is deemed to be US specific. It's deemed to be US specific because that's who showed up at the table at the beginning, but there's nothing about the architecture or design that couldn't apply anywhere in the world. And so if we get engagement from global partners who say, yes, this makes sense for us as well, I'd be very happy for the next release of it to not have a US flag, but to have a global flag on it, because it makes sense for us to do this everywhere. And while in Europe you're better than us in North America from a physical activity perspective, all of us can stand to improve, and all of us can stand to continue to encourage patients to improve. So please do take a look at the guide, do provide feedback. We're expecting to publish our first official release after ballot sometime this summer, and then we'll be continuing to push for implementation, and would welcome feedback and engagement from all of you. Questions?
Okay. So thank you for your presentation. It's a very interesting topic. I have been doing like health promotion projects as well, so it's really good to see that there's like some other work going on as well.
Okay.
I would like to talk to you about the condition.
Yep.
So I think it's a very simple approach to say like having too little physical exercise is a reason for doing more.
Yes.
So in our health promotion programs, we would have a wide range of conditions to lead up to more physical activities, ranging from being diagnosed with a chronic disease, having mental health issues, having too high body weight. So I would like you to like reflect on your conditions or your condition.
Yeah, I mean, we certainly weren't thinking that this was the only condition that was relevant. What we wanted to do is standardize how to express a condition that was specific to physical activity. We certainly expect that we would also see hypertension or diabetes or recent cardiac issues. All of those things are also reasons why you would engage in this process. But you might engage in this process when you don't have any of those things, that the only challenge that you have is this person isn't getting enough physical activity and therefore they are placing themselves at risk for bad things happening downstream. But yes, you would absolutely have the ability to have other conditions. We build on top of US Core, which means that condition generally is available and all of the things that you might want to say about condition are there and it's sort of expected to be supported already. We're just adding in, if you're going to claim to be conformant in this space, then you have to at least also have the ability to say this. But yes, you definitely want those other things.
Any other questions in the room?
So I'm curious, as you know, I've looked at this IG, and as non-technical as I am, I'm starting to think in practical terms, what will providers and practitioners and patients be able to do when this IG is rolled out that we can't do today?
So right now, today, you can walk into your GP's office and show them your phone and say, this is how much I'm walking or whatever, if you have a phone that does that. What this will enable is once they're engaged with you and you've got the app sitting on your phone, whatever app that happens to be, they can be monitoring from their office how things are going. Or your exercise physiologist can be monitoring more likely how things are going and engaging with you, reaching out with a questionnaire that says, hey, you seem to be, you started out strong, but things have tapered off. Where are things at? And so rather than engaging on the next office visit, which might not be for a year, you can be engaging more. And also, there are lots of patients that don't necessarily have a phone, but could be on a daily basis or a weekly basis going into their computer and saying, yes, I exercised this much this past week, here's the kinds of things that I did. And so there's an ability to share more than there was. Also an ability for the personal trainer to have access to pieces from the medical record that are relevant to them so that they can see certain things that might help them in figuring out how to best help you to do what you're supposed to do.
One final question from the room.
Okay. And other questions out over coffee?
Yes, thank you for your presentation. Twofold. So I was wondering about health education in addition to promotion. Yep. How are you considering maybe also educating the participants, the effectiveness of their participation in the physical activity? And maybe following up on that, are you also measuring the effectiveness rather than just the participation, for example, when it comes to certain indicators as blood pressure or otherwise?
Yeah, so from an education perspective, the IG is focused on exchange. So one of the supports that you would absolutely get from a personal trainer or a gym or whatever is education and training in terms of how to do whatever it is makes sense for you in the appropriate way. there is a little bit of interactivity in terms of, hey, I would like you to look at this video, or I would like you to read through this website. So there's an ability to have a bit of interoperability around education, training requests, and monitoring. Have they said, yes, I will, or no, I won't, and have they done it? From an interoperability perspective, you may or may not need that depending on what you're doing. If you're going and visiting the gym on a weekly basis, the education isn't going to happen through your app. It's going to happen through what the personal trainer tells you to do there. In terms of ongoing monitoring, one of our objectives is if we can standardize some of the basic data, then we can start to measure outcomes and start to look at, okay, people who are engaging in these programs, how much is it actually changing their exercise levels? How much is it actually changing their healthcare outcomes? And using that as evidence for what programs are working, what are not, and also using that as evidence to say, hey, these programs are demonstrated to work. It does make this difference in outcomes. Therefore, you should be paying for them as insurance programs or governments or whatever, because it's a whole lot more effective to do this, which costs this much, than it is to pay for the diabetes medications or whatever else that comes later.
Okay, thank you for your presentation and thank you all for attending. Have a wonderful lunch.